So, first things first, let's define pharmacokinetics. Pharmacokinetics versus dynamics. So, this is quite hard for people to keep in their head because they always get mixed up. So, kinetics is relatively equal to motion. And so what this is describing is, let's say you have a blood vessel here. And what you're describing is the drug going through the body in motion and how it goes up and down in the body. While dynamics comes from the root word power. And so this is the drug acting on, let's say, the body or the cell, then sending cell signaling down and then having its effect in general, effect on the body. And so pharmacokinetics describes the body's effect on the drug and whether it goes up or down, while dynamics is describing the drug acting on the body. So we're first going to talk about pharmacokinetics. So there's ADME. This is absorption, distribution, metabolism, or biotransformation, and then excretion. So sometimes you'll see this in pharmacology textbooks. So as far as absorption, the big thing I want you to get away from this is bioavailability. And so this describes how much drug has entered the body and how much ends up actually systemically circulating around. So different routes have different amounts of bioavailability. And so you have transdermal, you have GI, which could be oral, buccal, rectal, and you have IV, or we'll call this parenteral. And this is what we always use in anesthesia, but it's really important to recognize the difference between PO drugs and our IV drugs. And so the biggest thing here is that we have first pass hepatic metabolism. And so we have a hepatic vein and hepatic artery. Sorry, this is a portal vein and then a hepatic artery, both feeding into the liver and then eventually leading to hepatic vein, which joins the IVC. Giant structure going back to the heart. So a big thing here is that most of the gut has veins that lead to the portal vein. And so it'll have first pass metabolism in comparison to, let's say, buccal or oral, which will bypass any of this portal vein and leading to the liver. And so instead it'll have systemic absorption across the whole body and have almost 100% bioavailability. Only thing that's stopping it is the absorption through the actual mucosa. So we'll skip over absorption, but let's talk a lot about distribution. So the first thing to recognize is there's a lot of different types of tissues, and they may be vessel rich or vessel poor. And this describes the perfusion to any one of those tissues. And so there's rich tissues like brain, heart, lung, liver, etc. And then there's medium ones like muscle, and then poor perfusion ones like fat, skin, bone. And so these ones get a large percentage of cardiac output, while your muscles get a medium amount and your poor ones get quite a bit less. And so this helps to describe how fast a drug moves into any one of these compartments. Separately, we have to recognize, well, what is the mass or affinity of the drug for that compartment? So we have to recognize there's a difference between the perfusion to any of these muscle groups versus the difference of their affinity or size for that drug. And so when you're first looking at how fast a drug goes to a certain tissue, that'll be related to both the perfusion of it and also potentially its affinity for that, or solubility, let's say. Versus when you're looking after it's hit equilibrium, then it doesn't really matter how much that tissue is perfused per se, it just matters the affinity or size for that. And so a classic example is something like propofol. Propofol, when it first is entering into the system, it preferentially goes towards the brain and eventually causes sedation. And then later, it goes towards muscles and fats. And so if you want to look at the affinity for it, the affinity for a lipophilic structure like the brain or fat is relatively equal, but it moves towards the brain because it's faster and moves towards the fat because it's slower. So that's just to help differentiate between the rate of rise, which is equal to both the perfusion and the affinity of size or solubility, versus at equilibrium is just related to solubility. So let's talk about different factors that affect the ability for a drug to act on the tissue. And so, as you probably read, there's a law of mass action, which essentially says that the concentration matters. So the higher the concentration, the more likely that those drug particles will cross a tissue and act at its effector site effect. And not only will it have more effect, it'll also have a faster effect. So other factors that affect this include protein binding. And the two types of proteins that we have in our blood most commonly is albumin and alpha-1 acid glycoprotein. And this often binds acids, and this often binds bases. And so the big thing here is that if you have a high protein binding, then a very small change in, let's say, your protein levels might have a significant effect on your actual free drug concentration. This is different from patients or drugs that may have a low protein binding, because in these patients, if they were to potentially have a low protein state, they wouldn't really be that affected as far as its drug conversion or drug effect. So, third, lipophilicity. So, as all cells have a lipid bilayer, which prevents drugs from normally crossing. Now, fatty drugs are able to cross more easily through passive diffusion because they can be attracted to the inner fatty part of the lipid bilayer. Watery drugs or hydrophilic drugs aren't able to pass through, at least through passive. And so often we have these transporter membranes that'll let water-soluble or hydrophilic drugs be able to pass through. And so the more lipophilic a drug is, the more likely it can act at a certain cell to have a certain effect. And this is more pronounced at the blood-brain barrier. So most other cells eventually have a small amount of passive diffusion through those cell membranes, but at the blood-brain barrier, this cell membrane is so much more lipophilic that only drugs that are strong lipophilic can enter. The fourth is charge, and this also has an issue with blood-brain barriers because of the same reason that if something has an ionic charge or potentially just a polar molecule, so polar being that has a dipole, let's say from chemistry days, it's not able to cross because it has essentially an equivalent of an ionic charge. And so it can't easily cross this blood-brain barrier and act on the brain. And so the classic description of something like that is glycopyrrolate. So glyco acts as a acetylcholinesterase inhibitor, as an anticholinergic. So the classic example of this is glyco. Glyco tries to hit the blood-brain barrier, but because it is has a polar quaternary substituted molecule, it bounces out and isn't able to cross the blood-brain barrier and essentially doesn't have CNS effects from its anticholinergic activity, unlike atropine, which is essentially doesn't have a very specific non-polar attribute to it. So it can cross the blood-brain barrier and have its CNS effects, including confusion. And fifth, size can affect whether it can cross through a certain membrane. So I want you to remember all 5 of these because this will occur in multiple parts of anesthesia that we'll talk about later. And so this is really important to know, and we'll talk about how some of these states may change and how this might affect drug concentrations or drug effect in the body. Let's move on to the fun stuff of distribution. So first thing we should talk about is the idea of distribution in general. So imagine we have a graph, and this is concentration, and this is time moving forward. So when you end up having a drug delivered into the body, let's say IV, the drug will jump up into the body, increasing plasma concentration, drop down rapidly, and then start to peter out. So this part describes distribution. This is the part where the drug is in the central compartment and eventually rapidly equilibrates with the other compartments in the body. And so if you imagine, we can have different compartments. Let's say this is V1. V1 is also called the central compartment. And then let's say that we have a 3-compartment model. And so we can have V2 and V3. And so often we might describe that this might be, let's say, muscle or relatively fast equilibrating tissue. And this might be, let's say, fat or skin. And this might be very slow equilibration. This is relatively fast. And so what ends up happening is in distribution, the drug is first entering into this V1 compartment and it jumps up very high, but then eventually redistributes back out into the muscle and then eventually the fat. And so this concentration drops very quickly. Then, once it redistributes, we enter the second phase, which is elimination, or some people say beta phase. And so what will end up happening is that all that drug that moved into these other tissues will now move back into the central compartment as this central compartment is cleared. So this is clearance. And what ends up happening is that clearance can only clear drug from the central vascular space, essentially, because that's where your organs for liver and kidneys have access to. And so as this concentration drops, this concentration is higher and follows its gradient down into the central compartment, which means that you'd normally expect that this slope would continue going down. But because of redistribution back into the central compartment, this starts to slope off and you don't have as fast a drop in the serum. So now this describes a 3-compartment model. Now, whenever people are figuring out what the drug behaves like in the body, they may describe it as 3 versus 2-compartment model or even 1-compartment model. And sometimes the same drug in multiple studies might come out as a 2-compartment model in one study and a 3-compartment in another. The reason for this is more about how quickly they can rapidly sample arterial blood gases, blood of the serum concentration of the drug, and identify these very, very quick and subtle components of jumping high in the plasma concentration off the start and the distribution and redistribution of it. So it's more a mathematical representation of what's happening than what's probably actually happening. And so it's a little bit more dumbed down. In every single tissue is going to have a slightly different equilibration and a slightly different speed at which they equilibrate with the tissues. So one thing that comes up regularly is the volume of distribution in pharmacology. And so volume of distribution initially assumes a 1-compartment model, so just V1. But it's with the thought that part of this V1 totally encapsulates part of the drug, which means that the serum concentration does not see part of it, part of drug. And so if it doesn't see part of the drug, the concentration of this is much, much lower than you would expect it to be. And so pharmacists want to have a way of characterizing what you would actually expect the serum concentration to be and how to predict that with how you give a drug. And so with that in mind, they described volume of distribution, which is equal to the drug dose given over the concentration that you end up having in the serum. And so what you find is that essentially the more fatty the drug, the more likely it's going to have a high volume of distribution. So it ends up collecting all these fats, and the end serum concentration is much lower than you expect because there's not that many around in the rest of V1. While something that's not as fatty has a low volume of distribution. And so what's important here is that this only describes a one compartment model. And so when you start applying this over to a three compartment model, is that you realize that at each moment in time, there's a different concentration in the serum, and that the volume of distribution at each one of these times will be different, and it'll be changing over time as it redistributes into these different compartments and goes back into the central compartment. And so some people might use volume of distribution in pharmacy, but for anesthesia, when we're considering whether this affects the drug's clinical action, we can't really use volume of distribution well. We can understand in general how lipophilic or how fatty that drug is based off seeing that as a high volume of distribution. But other than that, it isn't extremely useful. So the next thing people thought might help is describing volume of distribution at steady state. And so the idea is that you have a constant infusion, and at some point you'll reach equilibrium with the other compartments. When you reach equilibrium with other compartments, you then sample the concentration and find out what that concentration is. And you could then do drug divided by concentration to find out what that is. Now, if it was to describe something like propofol, that would take quite a while for the infusion to actually get to steady state. But once it gets into steady state and it's gone into all those fats, you'd sample it and it'd be actually quite a low concentration. And one might decide, okay, well then we can calculate a loading dose, just like the way pharmacy describes maybe loading doses for, let's say, antibiotics. And so a loading dose is normally equal to the VDSS times the target concentration. So if you want to target, let's say, 3 milligrams per liter, then you would recognize, well, how much do you expect the volume of, how much the concentration to be at stable state divided by the normal drug. And then you try to figure out, okay, well, then we have to give a loading dose to get really high so that we can eventually hit the reasonable target concentration once it all dissipates out into the other tissues. The problem is that we care about minute-to-minute serum concentrations in anesthesia. And so what would end up happening is if we ended up doing this for propofol, we would get an extremely, extremely high dose. This would be so high that it would overdose the patient because you would get a giant, giant spike here, and the patient would essentially have a toxic or hypotensive reaction. All because you're expecting the VDSS somewhere around here when it's hit stable state, and you use that as your concentration. So this is essentially inappropriate. For our clinical application, at least. So in anesthesia, a 3-compartment model describes our drugs a lot better than, let's say, a 1 or 2-compartment model. So you may have seen these equations before, but let's talk about how to predict the concentration of, let's say, concentration plasma. And this is dependent on the time. So this equation will describe all the parts of this graph here with distribution and elimination. And if we're going to talk about a 1-compartment model, then you describe something with a large coefficient E, which is the natural number, to a rate constant, and your time. And this would describe normally essentially if this concentration was graphed log linear, then you would see essentially a straight line down. So this describes the first compartment model and showing a standard logarithmic drop in serum concentration over time. Now, if you wanted this to represent a 3-compartment model, you would have your coefficient, your rate constant, and you would notice that there'd be multiple rate constants plus a third. And so this equation describes this very well, because what you'll end up having is multiple decreases in concentration rates over time. So you can have 1, 2, 3, and potentially even more if you want to get more and more accurate. But each of these will describe the rate, alpha, beta, gamma, at which any of these are decreasing in the serum concentration over time. Now, when you try to apply a half-life to this, we end up having a little bit of trouble. Half-life very easily describes a log linear constant rate decay in drug leaving the body when it's a 1-compartment model. The problem is half-life describes the drug being metabolized or leaving the body. It doesn't technically describe what's happening at 50% of the original concentration in the central compartment. And that's what we're always measuring, and that's what we also care about, because that's what the brain sees. And so T1 half is about total drug in the body. But we care about 50% of the effect on the body. And so this really describes the central compartment. And so what we can say is that we're looking for the decrement half time, which is the time it takes for the serum concentration to decrease by 50%. Now, the problem with that is that is an ever-changing model. Here, it's a relatively fast timeline. But as you go further and further out on a 3-compartment model, that time gets longer and longer and longer. And so we can represent this with, let's say, a graph here. And let's say we were to run an infusion. And let's say we were to run it for half an hour. What would happen is you'd notice that there would be a decrement in that serum concentration, and it would slow down over time. And that the time here would be relatively short. But if we were to run the concentration or infusion for half an hour more, let's say an hour total, and then you were to see a decrement, while there's been more drug gone into both the fats and the muscles, and because of that, it takes even longer for those to equilibrate back out into the central compartment as this is being metabolized and cleared. And so this is going to take much longer. It's going to take even more of a slope like that. And so when that happens, you can see that the half time is much longer. And let's say you were to do even 2 hours out. And then you saw that even more fat has been filled up, even more muscle is filled up. And so when it's metabolized from the central compartment and this comes back into the central compartment, this central compartment takes even longer. And so then you'd notice that this time to get to, let's say, half is even longer. And so this is where the idea of a contact-sensitive half-time comes in. So what people often talk about is, let's draw another graph, and this time show constant infusions and what the 50% decrement time looks like over time. So this is still time on this axis. And this is the 50% decrement time. So if we plotted this drug and we saw that at half an hour, let's say 30 minutes, that it was X amount of time. And then at an hour, we notice that was even more, so 60 minutes. And then at, let's say, 2 hours, 120 minutes, you saw even more. You might be able to graph this over time and see that this decrement time goes longer and longer. And so what we can say is that the 50% decrement time is dependent on the time that you've infused an infusion for. And so what this is classically being described for as being opioids. And so opioids are so lipophilic that they distribute a lot to the fats. And then as you go longer and longer with your infusion, it takes longer and longer for them to seep back out. And so a classic opioid that takes longer and longer is fentanyl. So fentanyl gets higher and higher and higher and higher. And so this can be relatively hard to predict when you're running an infusion for, let's say, 2 hours or 4 hours or 7 hours, trying to recognize, well, when is this fentanyl going to wear off and I can wake up my patient. Now, another drug is sufentanil, which climbs to, but then tends to plateau off. And so after a couple hours, it can be actually relatively predictable how long it'll take for sufentanil to wear off. Another older drug that isn't used as much now is alfentanil, which also climbs up, but doesn't climb up as much after the 1 to 2 hour mark compared to fentanyl. So let's label this. Fentanyl, alfentanil, sufentanil, and then the one that I think everyone knows about and has a very constant decrement time is Remy. And that's because of two things. Remy. So this is due to both Hoffman elimination, which is just the natural product breaks down once it hits the blood. So let's say it's two components like this. It just happens to naturally break down into two components. And plasma esterases break it down. And so it never really has a chance to really seep into fat because it's constantly getting broken down, which means after 3, 4, 5 hours, it still has an extremely predictable offset time of, let's say, roughly 10 minutes. While some of these other drugs can take even longer. Now, technically, you could use this to your advantage. And you could run, let's say, a fentanyl infusion for multiple hours And what would end up happening is that fentanyl would have an extremely long decrement time once you turned off that infusion. It could be even hours, several hours. And so in some sense, it's more of a long-acting agent compared to, let's say, morphine. If you were to give morphine at the end of the case, that might last multiple hours. And so in some sense, you could potentially take advantage of this type of context-sensitive half-time. But at the same time, it can be quite difficult because it's hard to predict. And so if you've paralyzed a patient or you've had enough narcotics that they're apneic, it'd be very difficult to titrate fentanyl to the right concentration to ensure that they would be predictably able to be woken up at the end of the case. So as much as maybe it's useful to try something like that, it might be very difficult. So what I want you to take away from this is that this half-life that most drugs are described with is not clinically useful, and that the 50% decrement time is far more useful because it describes the offset of the drug. And so this is incredibly important to recognize the context. And the context, most importantly, is time. Now, let's go back and talk about clearance. And so, if we wanted, we could also draw a graph. And this time not linear, or not log linear, let's just have linear. And this is still time. And you could see that as the drug gets eliminated, the concentration goes down. This is still concentration. And so you can use your same equation, CPT equals AE to the negative alpha T to describe this type of elimination. So let's say we want to solve for half-life. We can still have CP, this time T1 half, which we know is going to be half of your initial concentration, because A would be here. So half A would be here. And so we can put half A on this side, and we know from the original equation that we can have E to the negative alpha and then T1 half. And so we can cancel and we can apply ln to both sides. ln e to the negative alpha t half. And when you apply ln e, you bring down everything. Negative alpha t1 half. We'll just erase that. T1 half. And this on ln of half is negative 0.693. And so we can move this alpha to the other side and take out the negative. 693 divided by alpha equals your T1 half. And so this equation, which is also often replaced with KE, or your rate elimination constant. This is called rate elimination constant. Describes your relationship with your half-life. So this rate elimination constant, KE, is also equal to your clearance divided by your volume distribution. And so if you put this in, you get T1 half equals 0.693 times your volume distribution divided by your clearance. And this is a really important relationship for normal pharmacology because this is an easy way to identify half-lives and when you recognize plotting the concentration over time as it gets eliminated from the body. And so what people could do is knowing the volume distribution and knowing that multiple time points measuring serum concentrations, they could then describe how to calculate your T1 half. The problem is that this doesn't exactly describe the clinical effects that we care about because we see the serum concentration drop off far faster and in a non-constant way because of a 3-compartment model compared to this. So as much as this is important, and you'll probably be quizzed on this later, this doesn't really apply clinically to our drugs when we're looking for the effect site. So let's go on to biotransformation. So most of you probably read about phase 1 and phase 2 metabolism. And so this is really just trying to create a metabolite that is water soluble so you can then excrete it. If it isn't water soluble, then your kidneys have a hard time excreting it outside of the body. And so phase 1 is some form of oxidation or reduction to ensure that the molecule is a little bit more polarized or ionic. And then phase 2 is often conjugating it with another substance to make sure it's even more likely to be water soluble. Now, a more specific point is talking about hepatic clearance. And so hepatic clearance, which is different from the total clearance that we talked about before, describes only how the liver is clearing the substance or metabolizing it. And so an often quoted thing in pharmacology is the extraction ratio. So extraction ratio. Or sometimes people even say hepatic or HER, hepatic extraction ratio. So what happens is that you still have your liver here. You still have your artery and your portal vein. So we have portal vein, hepatic artery, hepatic vein. And so what's going to happen is that drugs are going to move in to both of these sites and move out here and have some form of metabolism. And so the percentage of how much is metabolism is essentially your HER. And so a way to quantify that is that it equals, this is Ca, which is the drug that comes from both your vein and your artery. So Ca minus Cv. Cv will be the drug concentration when it's leaving the liver, and this is divided by Ca. So just a normal percentage. We can say that clearance hepatic is equal to HER extraction ratio times the amount of flow that's occurring through the liver per minute. And so we'll say that's flow or cardiac output. And so what we know is that the extraction ratio is also related to the intrinsic clearance of the liver. Intrinsic clearance, or CI. And so CI describes the enzymes in the liver and its function able to actually convert and use phase 1 and 2 reactions. And so a way to express the extraction ratio is intrinsic clearance divided by the flow plus intrinsic clearance. And so if you can represent that as your extraction ratio, this is equal to E, and you times that by Q, then this will equal your total hepatic clearance. Now, what we often talk about are two different scenarios. One where your intrinsic clearance is very, very high. Now, if your intrinsic clearance is incredibly high, then essentially this E is essentially 1. And if the E is essentially 1, then you end up with clearance hepatic essentially equal to your hepatic flow, which means that when your hepatic flow in certain disease states might be reduced, so is your hepatic clearance. So in a high HER drug that the liver can very easily metabolize, the more important thing to recognize as far as whether there's variation in your metabolism is whether there's a patient population that may have a low cardiac output or a low flow to the liver. And in those states, your extraction or ability to conjugate is quite reduced. If a drug has a low HER or low extraction, what you're really describing is as a low clearance intrinsically. So if clearance I is low, then what ends up happening is that Q plus your clearance is essentially equal to your flow anyways. Q plus clearance is roughly equal to flow anyways. So when you have clearance hepatic equal to clearance intrinsic divided by Q plus clearance intrinsic times flow, if this is essentially equal to flow on the bottom, then this and this would cancel out. And clearance hepatic is essentially equal or dependent on clearance intrinsic, which means that in states where you have a very low clearance intrinsic for the certain drug, any manipulation of those enzymes due to a disease state will have a profound effect on your clearance. And so both these may have clinical application because patients with, let's say, liver disease may have a very poor intrinsic clearance, which means that essentially in those states, a drug that is dependent or has very low clearance intrinsic could be even more elevated or potentially even toxic in these patients. The thing is, if you also have drugs that have a very high clearance intrinsic, liver disease may also affect them because liver disease ends up having often a low flow through the liver because of portal hypertension and congestion, as well as potentially congestive heart failure. And so oddly enough, drugs that have a high HER and low HER could be affected by liver disease. But relatively high HER drugs may also be affected by, let's say, low cardiac output states, CHF, potentially renal failure. But more than anything, you'll have to know the clinically specific things that happen with any specific drug. But more importantly, you'll have to know the specifics of any one drug that you care about, because there might be subtleties to how that drug interacts as far as potentially differences in protein binding, in the pH of the patient, in the cardiac output of that patient, and potentially even their volume of distribution, because they may have a larger amount of volume on board. So as much as you might try to use these mechanisms to try to predict whether a patient may have more difficulty or accumulation of certain drugs in their body, the more important way to recognize that is by looking at clinical studies.